Today, the topic of our lecture is Introduction to Chest Radiology. I'm your educator, Dr. Ali Imran, and let's get on with it. Okay, we'll start off with the fundamentals. First one is that chest radiology is the single most performed radiographic study in the whole world. Now, this single-handedly tells you how important it is and how widely distributed it is. So every doctor needs to have a good grasp of it, good understanding of it, needs to have a better judgment for it. So not only for their patients but also for their careers. Next, we have it is also used as the initial workup for many of the clinical presentations. Now, many patients present with certain symptomologies, with certain symptoms and patterns, and most of these require certain tests which are called the baseline tests. These baseline tests include the complete blood count, the urine routine examination, the ECG electrocardiogram, and the chest x-ray. So for the most of the presentations, chest x-ray has to be performed as a baseline to exclude certain diseases, to diagnose certain diseases, and everything in between. Next, it is also used to evaluate response to treatment. Is the treatment working for our patient? Is the treatment not working? Do we need to change it? Do we need to tweak it? Do we need to have some other discipline of treatment? Or do we need something else for the patient? All of this can be decided for the patient based on simple x-rays, on how the disease is progressing, how the prognosis is looking, and everything. Next, it is also used as a screening exam for the public health concerns such as tuberculosis. For tuberculosis, chest PA X-ray is used as a screening tool. Now, this is used for the general masses, especially in the countries which have high ratio and high numbers of tuberculous patients, such as the Indian subcontinent and the Southeast Asia. Next, it is also part of the routine general health assessment exams. Like I said, there are certain exams called the baseline exams, and X-ray is part of them. And these exams have to be conducted at regular intervals to assess both the health of the patient and to diagnose any preceding or preceded disease. So every person should undergo X-ray at regular intervals. Last one is that it is also used for preoperative evaluation of the patients who are undergoing general anesthesia. Now, general anesthesia is a very, very risky move. General anesthesia involves both patient to have being subconscious. It involves the muscles to lose their tone, and it is usually done during major operation. Now, if the patient is not fit or the x-ray demonstrates some kind of pulmonary or cardiac issue, that patient becomes unfit for general anesthesia and must not undergo GA. Or there might be something that can be done for that patient to counter that particular problem. So X-ray is always done as part of the pre-GA fitness. Next, we have the chest radiology modalities. Now, chest radiography can be done in a lot of ways. The first one and the primary one is the simple chest X-ray. This chest X-ray is done via the X-rays. It can be done both in the anterior posterior view and the posterior anterior view. Now, the posterior, anterior, posterior view means how the X-rays enter the body and how they leave the body, in which direction towards the radiograph. Another modality is the chest CT or chest computed tomography. But in this case, we use HRCT or high resolution CT. Why high resolution CT? Because chest contains lungs, and lungs are very delicate. They have very fine musculature and a very fine reticular endothelial network of connective tissue. So in order to appreciate changes in these tissue, we need high resolution, more detail in the CT examination. So instead of the normal CT scan, we prefer the high resolution one. Next is the chest MRI. Now there are certain diseases or infections where instead of CT scan, MRI is used. Now I will give you certain examples where MRI is used instead of a CT scan, but MRI is not uncommon for the problems of thoracic origin. Next, we have the pulmonary angiography. Now, pulmonary angiography is a technique where we investigate the vasculature of whole of the thorax and the lungs, primarily the pulmonary vein, the pulmonary artery, the lobar and the interlobar artery and veins. This is primarily done for pulmonary embolism because pulmonary embolism is a life-threatening condition which needs to be dealt quickly. Next modality is the echocardiography. Echocardiography is done via sonography. It is the only ultrasound study of the chest where the movement of the heart is studied with the ultrasound, the movement of the ventricles, the atria, the emptying and the filling of these chambers, the movement of the valve, everything is shown on the echocardiogram. Not only that, but we can also judge both the volumes and the uh, working, or you can say the tonicity of the ventricles. If the muscles are dilated, if the muscles are not, whatever the case is, we can diagnose this on echocardiogram. Next is the nuclear medicine. Now, nuclear medicine is what we use with a radionuclide. A radionuclide treats or gives certain functions to the organs. One example is the thallium scan. Now, when the thallium scan when the thallium is introduced in the body, it gives us a very good image of how the heart works. It tells us how the perfusion is working, how the ventilation is working, how good the heart is working, how good are the pulmonary veins or the lungs are working. So it gives us both the ventilation and perfusion and the working of the heart. And it is done through the thallium or the radionuclide study, the nuclear medicine. Next, we have the examples which I was talking before. Now, let's see that you have a patient with certain symptoms. Let's say cough, fever, some pleuritic pain, that is the pain in the chest cavity, leukocytosis, meaning the white blood cells are high, and rails in the left base. Rails are crackles or long crackles, means there some fluid in the lungs. If the patient present with these symptoms, we usually go for the normal x-ray, either in the PA view or the lateral view. But if your patient presents with progressive dyspnea, that is either with exercise or with time, the dyspnea or the difficulty in breathing exacerbates this, or if the patient presents with scleroderma or there's some kind of problem with the skin, either pustules, papules, or there's some kind of rash, or the patient presents with some interstitial changes on the chest x-ray, then we go for the CT scan instead of the conventional x-ray. And in this instant, we will go for the unenhanced HRCT. Next, let's say your patient now presents with hemoptysis. Hemoptysis is the coughing of blood, and it is a very serious issue. And he also presents with enlarged hilum on the chest x-ray, meaning there's some kind of inflammation or possible infection going on, and he might be suspected of having lung cancer. Now in this instant, we go with CT scan but with contrast, because these symptoms are life-threatening, should not be taken lightly, and should be done with due diligence. Next are the techniques. Now, routine chest radiography is done via two techniques. One is the AP or PA view. The second one is the lateral view. Now, in the AP and PA view is more common. Why? Because in the AP view, the heart appears larger, but in the PA view, heart appears in the normal size. So we prefer the PA view. The PA view actually looks like this. We have both the lung shadows, the heart shadow, mediastinum, both the shoulders, the diaphragm. So this is a good example of a PA chest X-ray. Now PA stands for posterior anterior. Posterior anterior means that the X-ray enter from the behind, the posterior, and leave from the front towards the radiograph. And in the AP view, it's the vice versa. The other one is the lateral view or the sideway view. Now in the lateral view, we can also perform an oblique view, but it's very rare to perform these days because we have very cheap CT scan and quite cheap HRCT scans. But in some diseases, in some situations, lateral view seems more appropriate than the standard PA-AP view. Now, as a good doctor, one must know how a chest x-ray is done or if it's done correctly. Now, first of all, we'll tackle the PA chest radiography. Now, this is a very good example of a normal and correct radiogram. Here, you can see both the apices of the lung are visible along with the clavicle. The mediastinum is visible along with the heart, diaphragm, vertebral column, esophagus. We have the costophrenic angle, and it is very clear. We can also appreciate the first rib, the clavicle, along with the edge of the body and the shoulder joint. If these requirements are completed, then it's a correct and a good chest x-ray. In your career, you'll find many chest x-rays, so you should know what constitutes a good x-ray and what constitutes a bad one. Now let's go for the lateral chest radiograph. Again, the apices should be visualized. The costophrenic angle should be visualized along with the diaphragm and the vertebral column. The mediastinum, it should also be visualized in a good manner, neither hyper nor in the hypo manner. Next, we have the search pattern. Now, whenever we look at a chest x-ray, we have to look at the different organs in a specific pattern. Now that pattern can change, but how you view the chest X-ray should not. But this is the standard way of how we search different organs for various diseases and abnormalities. The first organ we check in the chest X-ray is the heart. And the first thing we check in the heart is the heart size. How we do it is, first of all, we take the transfer width of the heart at its maximum, and then the transverse width of the lungs at their maximum. Now, if their ratio is more than 50%, that means the heart is large, and that is called cardiomegaly. Now, cardiomegaly can be because of two common things. One is cardiomyopathy or dilated cardiomyopathy, which dilates the ventricles and the atria. Another one is the pericardial effusion, where the water accumulates between the heart and the pericardium and gives the appearance of a large heart. Now, both of these can appear exactly same on the X-ray. You can differentiate between them by listening to the heart sounds. For the heart sounds, in the pericardial effusion, they will be muffled. But in dilated cardiomyopathy, they will not be muffled and they will have a very characteristic set of it. The next, what we study is the mediastinum. Mediastinum is the space between the both lungs. It contains your vertebral column, your trachea, your esophagus, your heart, and the hila of both lungs. Now, mediastinum on the X-ray, here it is. The left border of it is very important. Why? Because all major structures are usually visualized on the left margin. The first one is the arch of aorta, which then proceeds to the descending aorta, coming from the left ventricle. Then we have the pulmonary. Then at the number 3, we have the pulmonary artery. Now this pulmonary artery, the space between the pulmonary artery and the arch of aorta is what is called the cardiopulmonary notch, and it should be concave like this, not convex like the arch of aorta. But if you find it convex, that means that there's some kind of adenopathy or lymphadenopathy going on behind the heart, and it can be detected when there is the loss of this notch. Then at number 4 is the auricle of the left atrium. Auricle is actually the appendage or the extension of the left atrium, and it is normal. Then downwards we have the margin for the left ventricle. Now during the heart sizing in cardiomyopathy and cardiomegaly, it is the left ventricle and this area that extends over the diaphragm. Next we have the lung hila or hilum for singular. Now what are hila? Hila are complex structures which provide both the entrance and the exit for the pulmonary artery, pulmonary vein, the respective bronchus with the accumulation of lymph nodes. Now any inflammation of trachea will result in the inflammation of the bronchus and the inflammation of the hilar mass, or any inflammation will also give us lymphadenopathy or the inflammation of the lymph nodes. Like in the right mediastinum border, we have right hilar adenopathy, and it is a huge lymph node which is quite clear. Usually it is not so big, but in this instant, this hilar mass is huge, it's large, and it is very, very prominent. You can also see here on the left that notch, that cardiopulmonary notch is gone. So that hilar lymphadenopathy is happening at both the hila. On the right side we can appreciate it, but on the left side it is behind the heart. So the loss of notch gives us the idea of bilateral lymphadenopathy. Next, we have the pleural space. Pleura is the membrane which houses both the lungs, and it has a space between them. The space between the pleura and the lungs is called the pleural space, and usually it is empty. But sometimes during certain diseases, especially during pulmonary edema and some other infections, fluid accumulates, or during trauma, blood accumulates in the pleural space, and this is signified by the loss of the costophrenic angle. Here the angle is lost and there is this water level here. Now this can be blood, but this is an example of pleural effusion. But as you can see on the right side, the angle is intact. There is no loss. Now pleural effusion and the loss of the costophrenic angle can also be appreciated on the right side. As you can see here, this is the pleural effusion and there's the loss of the costophrenic angle. I must also mention that there's also another problem with pleura that we must remember, that is called pleural thickening. Now, the pleural space may remain intact, but the pleural membrane might thicken. It will thicken in effect to inflammation. Now, there are some inflammatory or irritant substances when inhaled cause the thickening of pleura. One of the most common substance is asbestos, and when it is inhaled it causes the thickening of the pleura, and that thickening of pleura will lead to the difficulty and pain in both the inspiration and expiration, because the thickened, inflamed, painful pleura rubs against the lungs. Next, we have the pulmonary nodules. Now, what are nodules and what is a mass? Anything less than 2 centimeter is labeled a nodule. More than 2 centimeter is labeled a mass. Here we can appreciate this little nodule here, which is actually a pulmonary granuloma. A nodule is a disruption in the parenchyma of the lung. So whenever there is a disruption, normal parenchyma of lung is replaced by some other tissue. We call it a nodule. And if that nodule is large enough, more than 2 centimeter, we call it a mass. Here, this pulmonary granuloma is actually due to histoplasmosis, and that granuloma is also causing lymphadenopathy, which is getting calcified. Next, pulmonary nodules are also called coin lesions. Why they are called coin lesions? Because pulmonary nodules have a very characteristic shape and size. They are always oval or in an ovoid shape. So if you ever find an ovoid mass or nodule in your x-ray, always investigate further. Always try to find out the reason behind it. It might be infection, it might be inflammation, it might be some kind of benign tumor, but mostly it is due to metastasis of primary tumors which are elsewhere in the body. One common example is the metastasis of the prostate cancer in the lungs. Next, we have the pulmonary consolidation. Now, they are usually said that there are three C's that we have to look out for when studying the lungs: the consolidation, cavitation, and collapse. First of all, what is consolidation? Consolidation is when the air inside the lungs is replaced by either fluid or some mass or by blood. Whenever it is replaced, it's called consolidation. It can also be referred as an infiltrate, it can also be referred as opacification. And the most common example of pulmonary consolidation is pneumonia, where large consolidations bilaterally, or in this example unilaterally, are visible on the X-ray. Another example would be pulmonary tuberculosis. But with pulmonary tuberculosis, along with the consolidation, we also see lymphadenopathy. And that lymphadenopathy is not reactive. It is usually matted and joint. And it's a very particular type of lymphadenopathy. Next, we have the atelectasis or the collapse. Now, the collapse of the lungs can happen, either the whole lung can collapse or the lobes of the lungs can collapse. Here in this example, only the lower lobe of the left lung has collapsed, not the whole lung, because the lung on the both sides are divided via fissures into various lobes. Sometimes the collapse is only lobar, that means only one lobe is, or the whole lung might collapse. When the whole lung collapses, it is usually referred to as pneumothorax, and it is usually presented on the X-ray by the shrunken volume of the lung but high density. Pneumothorax is again a very dangerous symptom, must be corrected on the spot, because of the pressure of the air on the collapsed lung, patient cannot breathe. So it has to be corrected as early as possible. Another C that I was talking about is called cavitation. Now, consolidation and cavitation are linked. When consolidation appears bigger, when it becomes that alveoli are destroyed, they're not filled with fluid or water or blood, but they are actually destroyed, and there's a cavity, a space devoid of tissue present inside the lung, that is called cavitation. And this usually happens in the immunocompromised patients. One such example would be aspergillosis in the AIDS patient, which is very, very common. Next, we have the bone shape and density. Now, when looking at the chest X-ray, we do not only look at the lungs, the diaphragm, or the heart, we also look at the bones, because we have the clavicle, the intercostal bones, the shoulder joints, the acromion joint, vertebral column. So if there's abnormally increased bone density, it usually signifies that there's some kind of tumor that has metastasized there, and that metastasis has caused increased bone density. So it must be evaluated. In the second radiograph, the bone density is reduced, and this has to be investigated. It can be due to osteoporosis, that is with age. It can be due to hypocalcemia. It can be due to lack of vitamin D or hypoparathyroidism. Whatever the cause is, it must be investigated. Also, on chest X-ray, fractures or hairline fractures, displacement of joints of both the sternum and the shoulders can also be located, verified, and diagnosed. Next, we have the interstitial lung disease. Interstitial lung disease is very interesting because in it, alveoli are not engaged. The interstitium, that is the connective tissue between the respective alveoli, is lost. And because of this loss, there's increased amount of air inside the lungs, and that gives the impression of more air inside the lungs. This picture can also be termed as an asthma, because in asthma we also have a large residual volume, but this picture along with this left right mediastinal bottom is usually an indicator of interstitial lung disease. Next, we have the pectus excavatum. Pectus excavatum can both be congenital and acquired. The acquired kind is usually due to some kind of trauma. This is the term when the anterior thoracic wall caves in, the sternum is displaced inward and outwards, and it is a very dangerous disease. If congenital, must be corrected by surgery. If by trauma, must be corrected, because this puts pressure not only on the heart but also on the lungs. Here is an example of CT scan. Here you can appreciate the sternum is dislocated. It's not in the center like it should be. It's dislocated, and the anterior thoracic wall is caved in. It is pushed inwards. So that's what called pectus excavatum. For the same, we have a lateral view. Again, you can appreciate the depressed sternum. Also on the PA, in pectus excavatum, we usually get a sign what is called a silhouette sign. Silhouette sign is when the apparent distinction between the vessels and the parenchyma is lost, like here. So usually in pectus excavatum, it's usually the apparent silhouette sign. It's not the actual one, but it is also diagnostic. When we have a caved in anterior wall along with the silhouette sign, it is usually an example of pectus excavatum. So what we have learned today, we have learned about the introduction to the chest radiology. We have learned about its fundamentals, how it's used, where it's used, how important it is in the career of doctors. Then we learned about the different modalities, the primary modality being the chest X-ray. Then we learned about its different projections, the AP, the PA view, the lateral view, and what makes these views the correct and what makes them incorrect, because one has to identify which ones are correct and which ones are incorrect. Then we learned about how to search for different abnormalities in the chest X-ray. There's a common saying that eyes cannot see what the mind doesn't know. If you haven't learned, if you haven't grasped the basis, if you do not know what looks the normal, you cannot find what is abnormal. So we looked at various abnormalities for the heart, cardiomegaly, we looked at lungs, we looked for mediastinum, we looked for the margins, both the right and the left margins of mediastinum. We looked for lungs consolidation. We looked at the lung cavitation. We looked at the lung collapse and the types of the collapse. And we also looked at one of the deformities, one of the very common deformities of chest, that is the pectus excavatum. Now, thank you for watching sqadia.com. Hope to see you again.